It's time for us to get started. I'm Don Parsons, a member of the board of the Colorado Healthcare Ethics Forum. CHEF is dedicated to bioethics education, consultation, and outreach. We welcome you today. We're delighted you could be with us for this webinar on a very important issue on first responder interaction with people in mental health crisis. I wish to thank particularly Constance Holden, another member of the CHEF board, Sheriff Jaime FitzSimons, and our moderator, Dr. Tom Dunn, for their collaboration in organizing this presentation. Regrettably, encounters between first responders with members of our community with mental health problems have sometimes resulted in injuries or even fatalities for the person or persons needing assistance. These unfortunate results may well have occurred in the past because of a lack of preparation and training of first responders in attending to people in mental health crisis. And this situation has become a growing concern, often to the first responders themselves. The limits in the 911 system in attending to mental health issues has reinforced inequities in early treatment of vulnerable patients. This presentation highlights 3 innovations of local Colorado agencies in addressing these inequities, including one model designed and administered through a sheriff's office, another designed with a paramedic and mental health worker, and the final model through Colorado Crisis services delivered exclusively by EMS providers in rural Colorado. These are sometimes referred to as co-responder programs. Our moderator will be Dr. Thomas Dunn, with panelists Sheriff Jaime FitzSimons, Assistant Chief Justin Harper, and James McLaughlin. Dr. Thomas Dunn is a professor of psychological sciences at the University of Northern Colorado and a staff psychologist at Denver Health. In addition to his clinical duties, Tom sits on the hospital's ethics committee and is also a longtime paramedic for Denver Health's paramedic division. His academic interests include the delivery of mental health care by first responders. We invite you to keep yourselves muted when not speaking and to enter any comments and questions in the chat box. We will have time to address questions during and after the panel presentation. Dr. Dunn will introduce the panelists. Thank you, Tom. Over to you.
Thank you, Don, and I appreciate that. There are a lot of people that helped bring this together today. Of course, our panelists, who I'm going to say, but I also want to acknowledge Amanda Hine and Stephanie and some of the other folks that were kind of doing some of the behind the scenes work. So we started thinking about this probably a couple months ago about how we could increase different models of interacting between people in the field who may be living with mental illness or substance misuse. And how is it that they come into contact first, usually with by first responders? One of the things that's remarkable about Colorado is an extremely robust both emergency medical services system, but also very progressive kinds of law enforcement and policing. And so as somebody who lectures and talks and writes about these sort of things, I can say with some confidence that the people of Colorado are well served, largely because of the creativity and the energy of particularly people who are involved in our program today. And so when we were thinking about the program, one of the things we wanted to address was both issues that affect urban Coloradoans, but also those in sort of suburban and particularly fairly rural. We're going to pick on Sheriff FitzSimons a little bit because he is by no means in an urban area, certainly has a rural response, but also has sort of a suburban. There are a lot of folks in Summit County that come down to Denver for work. So we're going to start with James McLaughlin today. James is the PACT program manager for the Ute Pass Regional Ambulance District. He looks after this, he's going to tell us about this PACT program, but it was put in place and designed to meet the needs of individual populations that historically have been neglected by different models of healthcare. And so please welcome James.
Thank you, Tom, for that kind introduction, and thank you all for being here today. I'm really excited to talk about our program and what we're doing for the citizens up here in Teller, Park, Douglas, and El Paso counties. I'm with Ute Pass Regional Health Service District. We serve 539 square miles of mostly rural environment. We have 16 providers and respond to about 3,000 calls a year. Of those calls, about 20% of them have a behavioral crisis or substance use disorder crisis component associated with them. So, and in 2014, we started looking at different ways that we could serve our populations. And we did a community needs assessment. And what we identified was there was a real underserved population in our community. There was folks that were fairly marginalized and not receiving the services as effectively and as efficiently as they deserve. And that was hard for us. We also identified the fact that we have, just by the nature of EMS, we have some reserve capacity built into our system. We have to have providers ready to respond to calls. And so we wondered if we could marry these two together. And so what we did is we put all of our providers through a 520-hour didactic training, all of our paramedics. So they've already gone through, most of them have an associate's degree in paramedicine. Over half of our providers have bachelor's degrees as well. And we went ahead and put them through an additional 520 hours of didactic training around community-based paramedicine. And that was, we took a biopsychosocial approach and looked at how you can treat the whole patient, not just the physical needs of the patient. So that was taught by Pikes Peak Community College, an accredited community college in our region, and utilized the National Community Paramedic Curriculum. In addition to that training, we put all of our providers, all of our paramedic providers through motivational interviewing, through a 5-day motivational interviewing course. We put them through screening, brief intervention, and referral to treatment, and the EMS provider resiliency program, because we thought if they were going to be out there treating other folks, we wanted to provide them with the tools that they could themselves make sure they're taking good care of themselves and their fellow providers. So at the end of that program, they also did an additional 520 hours of didactic or of practical training, where they sat in with community health workers, with psychiatrists. They also spent time at the behavioral health facilities doing intake work. And then from there, we created a program called the Mental Health Assessment Program, or MAP. And that's really what it is. It's a map to alternative destination and alternative services. Historically, the way ambulance services worked is when somebody's in crisis, they call 911, a big, bright, shiny red fire engine shows up, and a very expensive ambulance shows up, and the engine has 4 or 5 people on it, and the ambulance has 2 or 3 people on it, and then 2 or 3 police officers show up. We have 10, or more people crowded in this room around this person in crisis. We then drag them out of their house, none of us with the training or skills or ability to do that, and then take them to an inherently unstable environment, an emergency room, where they sit for 12, 24, 72 hours or more. And then we wonder why, A, our healthcare system is so expensive, and then B, why these patients aren't getting better. We're re-traumatizing folks through that process. And so our approach is we take these well-trained community paramedics that have a lot of community resources, and that's the most important piece, is we don't do this alone. We're not the content experts. We have just enough training to be dangerous on our own. Really what we count on is our community partners. We work collaboratively with our community partners. The first thing we do is we come in, we utilize motivational interviewing, and we try to de-escalate the immediate crisis. So we come alongside the patient. We try and understand what motivates them, what's driving the current crisis, and we actively listen to them so we can hear them mention change behavior. And as soon as they identify what it is that motivates them, then we work with that to help them gain the tools to to evade the immediate crisis. Once we've got them de-escalated, and this could take anywhere from 10 minutes to 2 hours, and our providers are empowered to spend as much time on scene as they need to help that person, to do it in their timeline. So once the crisis is de-escalated, then we medically clear them utilizing a 28-point peer-reviewed criteria that says, yes, you know what, this patient is medically stable and medically appropriate to proceed to the next step. So we do things like blood pressure, physical assessment, alcohol screening, drug screening. We do lab work, things of that nature. Once it's clear that the patient is medically stable and medically appropriate, then we do SBIRT, which is screening, brief intervention, and referral to treatment, to identify any substance use disorder, co-diagnosis type issues. And then from there, we do a Columbia suicide severity screening and an internal lethality assessment screening to identify the potential for suicidality, homicidality, whether or not they're gravely disabled, and then to what degree they might, their homicidality or suicidality might be lethal. So they're then stratified into a green light, yellow light, red light approach. And once that's determined, if they're in the red light category, that means that they're either suicidal or homicidal, have an active plan and intent. With those patients, we attempt to reach out to our partner, used to be Aspen Point, now it's Diversis, and we do a telebehavioral health assessment with a licensed clinician. And then that clinician determines whether or not that client meets the criteria for an M1 hold. If they do meet the criteria for an M1 hold, then they place them on an M1 hold and send us an electronic copy of that M1 hold. And then we work to get the patient placed at one of our behavioral health facilities, and then work it from there. And then we actually we do the nurse to nurse, we get them accepted by the receiving provider. We provide them with all the information, and then we directly transport the client to that destination, not utilizing an ambulance, utilizing a secured SUV that does not look like a police car. We really wanted to get away from that institutional, I'm going to jail kind of feeling. So for us, that's worked really well. And then if they're not on an M1 hold, they don't need immediate placement, then we work with the licensed clinician to get them placed on a safety plan. So that would be our yellow light category, and then get them set up with counseling. So we don't just say, hey, here's the number, call a counselor. We actually work to do a hard handoff or a hard referral where we have a date and time that they're going to be meeting with that provider. And then we model what it looks like for that client to actually go to that facility. So how are you going to get there? Do you have transportation issues? Can we address those for you? And then we work with our transportation partners, either the Senior Coalition or Ready Cab or one of those services to get them a ride if they need that. And then from there, if they're not in that red light or that yellow light category, and they're in the green light category, mild depression, just struggling with the stresses of life, but they're not suicidal, they're not homicidal, they're not in immediate crisis. Then what we can do is we can do soft referral handoffs where we give them a list of providers and suggestions and get them tied in with local services. So we also, identify barriers to accessing care, such as if they don't have insurance or things of that nature, then we try and address those issues as well. And then for the substance use disorder population, especially if they have a behavioral health component to it, that group is those folks, we really historically struggled with managing them and getting them to the right services that they needed. Now we've teamed up with Crossroads, which operates 2 detoxification centers in our community. So we get those patients, if they're actively under the influence or in withdrawal, then we get those folks set up with that detox facility. We medically clear them again, do telehealth visit with a ED certified physician, and get them any medications they might need to be successful through their detox process. We actually go and pick those medications up for them on the way to the detoxification center, and we take them there directly. So from there, we also work with several private detox facilities. So if a client would rather go to a private detox facility, then we work with them to get them there, kind of in the same process. And then if somebody needs to be on an EC hold, all of our providers have been trained on how to write EC holds and how to proceed with that application for emergency commitment. So we've been doing this since December of 2014. We've calculated about $3 million in downstream cost savings directly from diverting patients away from the emergency room unnecessarily. And we have about another 250 to 500,000 in associated or wake cost savings from not having to send an ambulance and a fire engine to every single call, not having to send 3 or 4 police officers, freeing up the police to leave fairly early so the law enforcement officers can get back into service, and keeping those resources available for other calls. So on top of everything else, for us, it's a force multiplier, because instead of taking 2 people in an ambulance out of service to bring somebody down to Colorado Springs, which is a 2.5 to 3 hour round trip, we have one provider that's dedicated to that person throughout the time it takes them to get them appropriately alternatively destinated to the best facility for them.
James, this is remarkable. If I could interrupt you for a second.
Yeah, absolutely.
We just want to make sure that everybody knows that this is being recorded, and we're going to post it on the CHEF website later. And so we appreciate people letting us do that. The other thing I wanted to ask you, and this is a remarkable program, the community paramedic is far different than the typical paramedic who's showing up off of a fire truck. It's a lot more training. But I'm just sort of curious, how is it that these individuals access you? And so if I'm in your community and I'm having a tough time, do I have to call a special number? Tell us a little bit about that. And then tell us a little bit about your role with the Colorado Crisis system, which allows people to call one number and have an assessment if need be within 2 hours, if you wouldn't mind.
Absolutely. That's a fantastic point. So we believe in all points of access. There's no wrong entry point into our services. So as Tom hinted at, you can access us through accessing the Colorado Crisis Services. So you can go to the Colorado Crisis Services website. You can text them using the Colorado Crisis text number, or you can call the 1-800 number to access Colorado Crisis Services. I have to apologize. I don't have that number for you right this second. I'll have it for you here in a minute. But you can access the Colorado Crisis Services directly through any of those resources. And the rule is that within 2 hours of the request, and actually within 1 hour for certain areas, we will be on scene. We've never had a problem, knock on wood, meeting that response time. Generally, we're on scene within 15 to 20 minutes of the request. But we also take requests from any law enforcement officer in our community that we work with. We also take requests from private physicians' offices. We take requests we actually work with our local critical access hospital because they don't have a behavioral health person on staff full time. So they can actually access us anytime, day or night, 24 hours a day. We'll send a MAP medic over, or a community paramedic with MAP services over to do an assessment of a patient that's in the emergency room, either with substance use disorder or behavioral crisis. Also, if one of our providers on the ambulance or one of our local fire agencies arrive on scene and they identify a client who's in behavioral crisis or in substance use disorder crisis, they know that they can refer to us and make a request. That not only includes folks within our district, but if the ambulance, EMS services, and law enforcement agencies outside the area are willing to drive within our district, we will actually rendezvous with them at set safe locations and do the assessments there. The thing I'm most proud about, and what I'd like to end with my presentation today, is these are hard clients that we're working with. They're in their darkest hours, and they're really struggling to find the services that they need. But what we've been remarkably surprised with is, on a scale of 1 to 5, where 5 indicates absolutely excellent service, the score that we our average score for satisfaction from our clients is 4.6 out of 5. So not only are we reducing the cost of care and improving access to care and making sure that clients get where they need to, when they need to, we're also doing it in a way that makes them feel and empowers them to be part of the process and have some say in what happens. And I think that's so important for them. So with that, I thank you guys for your time, and I look forward to hearing the rest of the presentations.
James, it's a remarkable program that you have. And for people who are not familiar with first responders and how the EMS system typically works, it is a remarkable program that my only fear is how difficult it may be to duplicate. Where is it that you've gotten your funding, and how is it that you partner with your 911 center? Maybe you could tell us a little bit about that. And then if anybody else has questions, if you put them in the chat for us.
Absolutely. So in building the program, the first thing was collaboration and working with partners. So one of the things we did early on is we adopted an already peer-reviewed, evidence-based assessment tool. And then we went around to all of the physician advisors for all the behavioral health facilities. And we said, hey, here's an evidence-based tool. You can add anything you want to this tool, and you can take anything away from this tool that you want. All you have to do is bring the evidence to support it. So we settled on the 28 criteria, and we haven't had, knock on wood, we haven't had a single sentinel event since we started the program in December 2014. We've been able to safely transition each and every one of these patients to alternative destinations. So we reached out to all of our law enforcement partners. They run the dispatch centers in our community, and we shared our vision with them, and they were like, yeah, I know, this is amazing. This is exactly what we need. And every single one of our law enforcement partners has embraced the program since day one. So that was really how we got dispatch involved. And then our funding is multifaceted. First of all, in a rural environment, ambulances don't make money at all. I mean, you bill for services, but the reality is you collect about 20% of what you bill. And so you're losing money. So we are a tax-based entity. We receive a small mill levy and a half-cent sales tax because we're a health service district and not an ambulance district. And that offsets about 60% of the cost of the program. And then the rest of the program costs come from the Colorado Crisis Services contract. So we are a subcontractor through Beacon Health Options, and they are the Southern State contractor for the Colorado Crisis contract through Office of Behavioral Health. And then we receive funding from them to provide the services that we provide. And the cool part about that is there's never a charge to the client for the services that we provide. So if they're transported to an alternative destination, they never receive a bill from us. If we assess them on scene, they never receive a bill from us. They can reach out to us as many times as they need to and get the services that they need. And then we've teamed up with a couple of partners that really add some back-end power to this program, and that is Front Range Clinic. They offer mobile medication-assisted treatment in our community. That's the first time that's ever been offered. So if you have someone with opioid addiction or other substance use disorder crisis, we can actually get them in, get them set up. Those folks come in once a week to our office and provide the services in our parking lot literally from a Winnebago. It's not a flying Winnebago, but a Winnebago. And then we've teamed up with Viewpoint Psychotherapy, and once a week, that's actually why I'm kicked out of my office today and I'm working out of the classroom, is once a week they take over my office and they see patients who need medication assistance. So we all know that with behavioral crisis clients, one of the things they suffer with is maintaining medications. And so we brought this nurse practitioner in. Before she got here, the average wait time for one of our clients to get into medication treatment for their behavioral crisis, to get with a prescriber, was 30 to 90 days based on their payer. Now we can have them with that nurse practitioner within 7 days.
It's remarkable, James. It's just remarkable.
it's such an awesome component. We also have formed the Teller County Mental Health Alliance, which is a bunch of behavioral partners in the community that have come together. And once a month we meet and we set goals and objectives, and we have core measures that we measure. And we've got a governance, and right now what we're building is actually an internal referral service. So, when you make the referral, when the referral is received, and when it's been acted on, and what the outcome of that referral was. So we're real excited about that piece. We're hoping to have that online within the next year. And then finally, our last partnership is also with Viewpoint Psychotherapy, where they do follow-ups on any patient that's seen in an emergency room in Teller, that lives in Teller or Park County. So if they're seen in any emergency room in the state and they live in Teller or Park County, then they get for behavioral or substance use disorder crisis, they get a follow-up within 5 days to make sure that they understood their discharge instructions and that they were able to get set up with the services that they need. So
it's just something remarkable. You all are absolutely leading the way in how other agencies, particularly in rural areas, may be able to function. And so I thank you very much. So we got a question. James, how many resources have you implemented, or how many responses?
So we like I said, we run about 3,000 calls a year, and about 20% of those are behavioral health or substance use disorder crisis. And we always initially we may also send the ambulance, but we always initially send a community paramedic to those calls. And about a third of the time, they end up going to an alternative destination. About a third of the time, they stay at home. And the other third of the time, they end up having injuries or illness that needs to be evaluated in the hospital. Although our statistics this year are treating a little bit differently, because we've added telehealth, where we have the ED physicians, and we're seeing that only about 25% of those clients are actually going to the emergency room at the end of 2020 through October, November of 2020, and then into January of 2021.
It's remarkable. We really appreciate that. Unless there are any other questions, we're popping into the chat. I don't see any. Amanda, do you see any?
No.
Okay. So again, James, thank you very much. I appreciate that. And I invite people in the audience to reach out to James if you have any questions. At this point, what I'd like to bring in is a more of an urban perspective. And so I'd like to bring in Assistant Chief Justin Harper. Chief Harper is the Director of Denver Health's Paramedics Education Department, where he oversees the training and continuing education for 300 line paramedics and almost 1,000 Denver firefighters. He's been intimately involved with the Denver STAR team. It's a co-responder model of a paramedic and a licensed clinical social worker, which has been getting some remarkable national press, largely because of numbers that have just come out. And so we're really excited to have you, Chief Harper. Thank you.
Hey, thanks so much, Tom. I appreciate the opportunity to be here and talk a little bit about the STAR program. And thanks for the introduction. So my name is Justin Harper, and I'm a paramedic. I'm one of the assistant chiefs for the Denver Health Paramedic Division. And like Tom said, I oversee the education and training, which includes community outreach for the Denver Paramedic Division. So that's how I sort of became involved with the STAR program. So in November of 2018, the ballot initiative passed, and it supported funding for the Caring for Denver Foundation by the tune of about $35 million. And one of the initiatives in this was to look for alternative responses to behavioral and mental health crisis and substance misuse. And so a team of folks driven by Denver Police Department really should have a lot of the credit, if not all the credit, for the initiative of this program, really wanting to get the proper resources to people in certain situations, and recognizing that a uniformed police officer may not be the right response in a lot of these situations. So really a lot of credit goes to the Denver Police Department for initiating this. And what we did was we headed out to Eugene, Oregon. That was Denver Health, MHCD, so Mental Health Center of Denver, and DPD. The teams went out and toured Eugene, Oregon, and their Cahoots program. Some of you may be familiar with that. It's out of the Whitebird Clinic in Eugene, and so it's a community response model that they really based the STAR program on. Eugene's a lot smaller than the city and county of Denver, and we have some unique challenges here. So it wasn't something that they could just take the blueprint and implement it. We had to really scrutinize our program and try to figure this out from the best perspective to serve the most people that we can and do it safely. And safety is really one of our primary concerns as we rolled this out. So the support team assisted response is what we came up with. We contracted with MHCD to provide a mental health provider, and then we decided to put a paramedic on this resource, especially for the pilot. What we really wanted to do, because we were going to have calls, 911 calls coming in from a different perspective in a different way. We wanted to have that paramedic there to be able to catch any sort of, medical problem that might have sort of slipped through the net of that 911 system. So we wanted to have our real experienced, trained healthcare providers, our urban paramedics out there with an opportunity to catch any of those issues. So initially, for the 6-month period that we started this, we ran about 750 calls. This was the calls that we run. So they're filtered through the 911 system. They basically come in through our dispatch or communications center for the city and county of Denver. And the calls that we're looking for are public assist that would qualify for the STAR van, intoxicated person, suicidal, the suicidal series. So that is in our 911 system that will qualify for 3 or 4 different types of suicidal calls, welfare check, indecent exposure, trespass or unwanted person, and then the syringe disposal, which is through our Harm Reduction Action Center. So those are the calls basically that would filter through the system and prompt a STAR response. We only ran the pilot, and we're still running the pilot, as a matter of fact, in District 6, which is the downtown Denver area and Capitol Hill area. So our most densely populated and highest call volume area in this city. So like I was talking about, for the results of that first 6 months, about 750 calls for data. That's about 3% of the total call volume for the Denver Police Department. And we had some interesting findings in that time. And I think most significantly in that time, of those calls, there was not one single call by the crew of our STAR van for additional resources with the police department. So once the STAR van was assigned and responded to the scene, they did not need any sort of police backup, and they were able to disposition these calls in a different way. And so they're able to transport the patients to either a mental health Center of Denver facility for treatment or for intake, or they were able to transport to shelters, local area shelters. They were able to problem solve whatever the issue is. If it's a trespassing problem, or a problem where somebody's indecent exposure, where they're changing clothes out on the street, they were able to offer opportunities to help people in a different way. And so that's really what this program is about, is the opportunity to provide services. And so the van works 8-hour shifts, and they're running about 6 calls per day. The numbers at the 6-month period were at about 750, were just over 1,000 at this point. And let's see here, I had one other thing. So the time on scene was the other piece that was pretty interesting that came out of the initial survey, and that was our average time on scene is about 24 minutes versus 34 minutes for police and fire and EMS crews. So less time on scene for the STAR van, obviously better outcomes with providing these services in a different way, and that's sort of the overview of the STAR van. And I'm happy to answer any questions that anybody has.
And Chief, also a remarkable program in a completely different setting than we're hearing from James. And so one of the things I wanted to make sure I understand is it sounds like this STAR unit only operates on a slice of the city, and that 6 calls in an 8-hour shift is a busy day. What are you thinking about what might happen if this were offered in the other 5 police districts?
Thanks, Tom. The recommendation out of the first 6 months is that we're all considering STAR to be a success. We recognize from emergency medical services, from the police department perspective, from the community perspective, this is a resource that is clearly much needed within the city and county. And so the recommendation here is to expand, and that's what we're working on right now, is how do we expand this with community involvement, with our public safety partners involved, and obviously 911 involved in the process. So how do we expand this? How do we expand this responsibly? But realistically, I think the future state for the STAR van would be to have 1 STAR van in each and every district, police district that is in the city and county of Denver. That would be the end goal. And I think we're all pretty much aligned with that goal. It's just about right now, how do we make that happen funding wise?
And so I know that MHCD also embeds licensed clinical social workers with Denver Police. And so that Denver also has this co-responder that's more on the law enforcement side. So maybe you can talk about how is it that these 2 programs coexist? Are there particular calls that are going necessarily to the police side of the house versus the EMS side? Maybe you can talk a little bit about that.
In the co-responder program is working very well for MHCD and for the police department. The conversations that I've had with the clinicians that are working both sides of this, so they've done some work on the co-responder side, and then they've done some work on the STAR van side. And so when we work on the STAR van, we're dressed a lot like you, Tom. We're dressed as not in the uniform. We'll have some identifying name badges and things like that. But we're pulling up in the STAR van in a way that's very different, and we're greeted by our patients or our clients in a different way, and it's far more welcoming. Having been a paramedic for 25 years, I can tell you, and working on the STAR van myself, I can tell you, it is a completely different experience, and it is folks are they're much more relaxed. They're much more willing to have conversations, and there's a lot less pressure there, and a lot less fear of sort of incarceration or a negative outcome. And so I think we're having more positive interactions. And I'm not saying that the co-responder program isn't the same, but it is that they're not having positive outcomes, but it is a uniformed police officer with a mental health worker, so that they're
pulling up in a marked police car.
Exactly.
And maybe with another unit covering, and that's certainly starts things off a little bit differently versus healthcare providers.
It certainly does, and it requires an ability to navigate that scene, a lot differently. And so the police officers that are assigned to that co-responder unit are very special individuals who interacting with them, you can tell that their approach and their commitment to the community is different. And so they approach these calls in a manner that is respectful and great. I think, though, getting away from the uniform and finding an alternative really does look like the STAR van if we're going to be successful in helping folks in a different way and providing support specifically for those experiencing mental health crisis, for those experiencing substance misuse crisis, and for those who are just homeless and experiencing those associated problems. How can we help in these situations in a different way?
So one of the things that we heard about with James is the sort of the community connections that they've been able to forge with a number of different providers. And so Denver Health is sort of unique in that it's a large healthcare entity that has a lot of its own behavioral health depth. But Dunn Parsons is asking, what connections do you have with community mental or behavioral health providers other than Denver Health, if you do?
You know, if we're looking at areas of opportunity moving forward, the difference between our program and what they have in Eugene, Oregon is they have this White Bird Clinic in Eugene, Oregon, which is an incredible resource that a lot of the patients and a lot of the clients that they interact with are going to this White Bird Clinic. And so the services that they provide there are not exclusive to mental health. And we all know that substance misuse can certainly exist outside of mental health connections, mental health issues. So NHCD is not always the answer for every single one of these problems. And so what you've touched on there is our future opportunities to build more connections within the community, to have more resources. The Harm Reduction Action Center is it's a great example of how we can help these folks to do needle exchange and how we within the STAR van can be a part of that connection. But there are more of those connections that are certainly needed. And especially if we're talking about having a dozen of these resources roaming through the city at any given time during the day, we want to be able to have positive resources to be able to take folks that, obviously for mental health issues, through Mental Health Center of Denver, but also substance misuse. How can we get them housing? How can we get them other types of resources and counseling? And so that's what we're looking at, leaning towards the future.
It's been interesting as somebody who sort of pays attention to field providers meeting mental health needs. The STAR program has gotten quite a bit of national news, it seems, particularly lately, but over the summer. What is it that you think is appealing to these reporters or these journalists? What is it that the STAR unit is doing that is unique and seems to be getting a lot of attention and high regard?
I think we saw a lot of calls in the spring and early summer to defund, and you'll hear this term and defund the police, and let's allocate money in a different way. And I think that's both interesting and concerning to people. What does that mean, defund the police, and what does it mean to change the way that their funding structure works? And I think that's why this has generated so much interest, is because this necessarily was funded by a ballot initiative. But I think that in the future, this could be something that is actually a budget initiative for Denver Police Department or the city and county of Denver, which is, essentially one and the same. So the interest in my mind comes from that perspective of what does it look like to put resources, not necessarily into policing, but into specifically helping people. And what is the outcome? Does the 750 calls where we didn't have the police department responding, does that correlate necessarily directly to less incarceration? Does it correlate to less violent encounters with the police department? Does it correlate to less deaths? And so I think that's the interest around this. That's the driver, especially for the national interest. And we're starting to see many other communities pick up very similar services to this and modeling off of Cahoots and modeling off of STAR.
It's a remarkable program. Maybe you could talk a little bit more about the other initiatives that Caring for Denver's doing. I know that there's training efforts for all of Denver Fire and Denver paramedics.
Yeah, they put together the ballot initiative language, which was great for us. Had some funding for training for first responders around de-escalation, around mental health and substance misuse awareness, and also some diversity education, diversity, equity, and inclusion. And so, thank you so much, Tom, for your involvement in that process. We were able to come up with a 2-hour long training for our paramedics and firefighters here in the city and county of Denver that is really pointed at how can we do a better job. Not only, it's great that we have this resource with the STAR van, but we know right now we're not going to be able to reach all of the folks that are out there that have this need. So how can we do a better job as healthcare providers? When do we need to recognize that we need to be in charge of this particular scene or this particular situation? And how can we also, the other piece of this, and that you've been very instrumental in this, Tom, in helping us understand that the police department has really changed their approach. They're implementing a lot of de-escalation tactics. They are working hard with their community to avoid some of these really bad outcomes. And so how can we as paramedics that are called to this scene, how can we continue that process and support them through some of these calls? And so that's what that training has been effective for. And we're very thankful for your involvement in that process as well.
I appreciate thanks. I wasn't trying to plug my involvement, but it's a remarkable thing, and we really appreciate your talking about it. And so if there are any questions for Chief Harper, go ahead and put them in the chat. And so again, remarkable things that are happening in Colorado, and I'm proud to be part of an organization that is sort of leading the way and getting lots of press. Our next panelist, unless we have some questions for Justin, is the Sheriff of Summit County, Sheriff FitzSimons. He is a 31-year law enforcement professional. He's been the sheriff in Summit County since being elected there in 2016. He spent a chunk of his career with the Los Angeles Police Department. And as he took over the sheriff's office, he's developed a number of community and jail-based programs to be able to help those who are particularly in need and who are also struggling with different behaviors that may may not be in line with our laws. And so he is a remarkable program also up in Summit County, where they overseeing a co-responder program, which is a little bit different. I'm looking forward to hearing him talk about. There's a law enforcement piece, and how is it that they in Summit County have merged both a paramedic, a behavioral health provider, and also a law enforcement provider, and how they're able to get into a number of different communities in a big county with a lot of people driving through an I-70, but also lots of people coming to visit and coming to ski. And so, Sheriff, I really appreciate you joining us today.
Hey, thanks, Tom. Thanks for the introduction, and thanks for inviting me to the panel. A little context for the people that are watching this or listening to this. Back in 2014, as far back as 2014, Summit County as a community started becoming itself in crisis as a whole. And we started seeing an escalation in suicides. And so around that time, law enforcement here in Summit County got together, and we decided that we would start training all of our cops in crisis intervention training, CIT training, which is a really involved 40-hour school where law enforcement learns to deal with different people in crisis and be able to tell the difference between someone with a mental health crisis and someone with maybe learning disabilities or developmental disabilities, and to sort of sift through those crises. And so we started training people. By 2016, I would tell you that our suicides continued, and I think it was around 2016 that our community as a whole had enough and rose up, and the leaders of this community, all the leaders of this community, got together and decided, what could we do about our crisis system? We felt the crisis system was failing us. We felt our community was suffering, and we started an initiative called Building Hope here. And it was a mental health initiative that was grassroots community driven. And it was formed to reduce stigma in the community, provide training to the community, provide activities, as well as a pathway to resources for people in the community suffering from mental health issues. But by 2018, we also passed a ballot initiative here in Summit County. That one of the things it covers was mental health, and $2 million a year from that tax initiative started going to mental health since 2018. So it was around then that I started, it was around when I became sheriff, but certainly between 2016 and 18 that I really started researching better ways to serve the community because of our crisis system. We'd all felt it let us down. And I started looking at co-responder units. And at the same time, I started looking at our jail-based system, mental health system, to see, what a better way maybe we could also do it in the jail, since everyone is part of the community, whether you're currently locked up as an inmate or you're out there in the community. And so I started looking at all these programs across the country, here in the state, and started, treating everything I came across sort of like a buffet. Started taking all the things I liked about different programs and started to build my own program and formulate my own program. And what we came up with was a co-responder unit that is made up of a deputy, a clinician, a mental health clinician, and a case manager. And they work as a team, and they're a dedicated resource. I mean, it's not as you heard before in some of these other programs, it was not a uniformed officer, it was not a patrol officer, and it was not in a marked vehicle. We designed a program where the clinician and the deputy respond as a team, and they would respond in an unmarked vehicle, and they respond in plain clothes. And we found that was the best way to reduce stigma immediately on scene of any call. I would tell you that, the case manager is an integral part of that team. And I would tell you that in the moment of crisis, that deputy and that clinician, have the heavy lift, right, of trying to stabilize this person in the community. But I would tell you on the back end of it, it's the case manager then that has the heavy lift of bringing all these community resources together and keeping this person stabilized, the clients. I would tell you that prior to standing up a co-responder unit here in Summit County, what happened in our crisis system is it became the default for law enforcement or fire and EMS to take everybody with a mental health crisis to our emergency room. You heard this about these other programs. And as a result, we literally broke the back of our emergency room of our local hospital because it became also a dumping ground for people in crisis. So by default, everyone that went to a hospital here in Summit County out of our community probably ended up walking out of there with a few $1,000s ER bill, and then got sent to a community mental health center. And by the time they got back into the community, they have lost their job, they've lost their apartment, they've lost their car, they've lost their pet, they've lost their family, and their life is one more time in crisis. So I would tell you in 2020 is when we stood up our co-responder. We call it the SMART team, System-Wide Mental Assessment Response Team. We stood up our team, and I would tell you that in 2020, because we've only been up a year, in 2020, Summit County had over 1,000 calls for service that were related to mental health. Our SMART team touched all those calls either directly or indirectly. And what I mean by that is either they responded to those calls or they were referred to those calls by one of our other public safety municipal agencies. But as a result, we stabilized in 2020, we stabilized in the community in place over 200 people, 219 people in the community that did not go to an ER, that did not go to a mental health facility, that were actually able to be stabilized on scene, and then followed up with a case manager that came along and helped them sort through whatever needs they had that put them into crisis. And our case management will continue to follow someone as long as that person wants to be managed and as long as they're receiving services. What's also unique about our team is we work really closely with our district attorney's office and the courts. And in 2020, our first year up and running, that we were able to divert any call we had that had a criminal nexus. So what that resulted in is this team in 2020 made 0 arrests. And I think that's really important. Nobody got arrested. Probably more importantly, or just as important, is the team had 0 uses of force. So anything that they came and encountered with, they were able to de-escalate immediately and stabilize in place. The other, number to be proud of is that Whereas I said prior to the team being stood up, it was a default where everyone went to the ER and probably got M1 and sent off. This team only M1 20 people in our community in 2020. So it's some
So by M1, you mean the involuntary treatment. That's
the
a
mental
72-hour
health
mental health hold that can
Yep.
be started by a police officer.
Yep.
So it's remarkable that partnership that you have with those folks. Sorry to interrupt you, Sheriff.
Oh, no, not at all. So our team has relationships with 2 hospitals on the Front Range where we're able to direct admit from the field. So bypassing the ER one more time, as well as, like I said, since they respond in an unmarked car, they're able to transport. We do our own transportation. So those 20 people got transported by us in an unmarked vehicle, and obviously in the least restricted means possible. Again, all to reduce stigma. What's also unique about our team is because of the way we're funded, this team responds countywide. And what I mean by that is there's 6 other jurisdictions here in Summit County besides the sheriff's office. And we handle the mental health calls in every jurisdiction. So the team not only monitors the radio, as I said, and responds to these calls throughout Summit County, but also we have a robust referral system where any of these public safety agencies, fire, EMS, community partners can absolutely make a referral to our team. And the case manager or the team will immediately follow up with those referrals. Our team also provides training to all the local agencies, police agencies, fire and EMS, community partners. We have quite a robust community partner group as well. We have over 15 community partners, stakeholders that come to the table with the team, both the jail-based team and also our community-based team to come together. And again, we've been doing this as a community since 2016. So it's remarkable how involved the community is. I would tell you this team would absolutely, hands down, not be as successful as it is without those community partners. There isn't a need that someone could have in this community that the SMART team could go to their partners and not meet that need and help stabilize that person and keep them stabilized.
Do you mind giving us some examples of some of those community partners and how you forge those relationships and so on?
Well, I mean, they're literally, some of the important ones is like we have a family intercultural resource center where they could go for rental assistance, food insecurities. Building Hope, our mental health initiative, we have a program through them where our SMART team is able to give what we call mental health scholarships to clients, which gives them 12 free therapist sessions with a whole host of therapists that we have contracts with that the Building Hope pays the bill. We have another organization that just gave us, $1,000 in gift cards where the team can hand out gift cards to people for immediate needs on scene of something. But, the resources they have in this community, like I said, there is no wrong door in this community, certainly for anybody, because of our partners. Let's see, what else can I tell you about the team?
Well, I appreciate hearing about the team, and I'm sort of curious. There's been a lot of discussion lately, and Chief Harper brought up this idea of defund the police. And on one hand, if I have a bad guy breaking into my house, I want the police to be well funded and be able to respond immediately. And so I'm just sort of curious from your side of the how you see things in law enforcement. How is it that you see? Do you think that American policing is changing? Do you think there are opportunities to do things differently? I worry about. It seems like every mental health provider I know on their outgoing message says if this is an emergency, call 911. And many systems, that means send the police. And in some sense, now the question is, okay, are you sending the police because what this person is doing is bad or wrong? Right. And so I'm just curious how it is that you see things happening, and do you think this is dangerous to say these sorts of things? Does it make sense to take some things off the plate of the line patrol officers or deputies? Maybe you could talk a little bit about that.
I would tell you what police work is always changing, right? It's changed in the 3 decades I've been in it. It continues to evolve. I would tell you, no police executive worth their salt would argue against police reform. It's obviously the way that it's carried out that's important. To me, I would tell you that it comes down to leadership and training. I would tell you, don't defund the police, actually give them more money for training. But as far as co-responder teams, co-responder is another word. As you've seen by the 2 previous presenters before me, co-responder is synonymous with the way it was described earlier by Justin, of a uniformed officer in a marked car with a clinician responding 2 different ways. My team responds in the community. You wouldn't know if it was the pizza delivery guy or my co-responder team, which really is pretty unique. And as Justin pointed out, it absolutely reduces stigma. It's definitely a different approach. It definitely changes the tone of that call. But I would tell you that, as you saw from the 2 presenters before me, it's different for every community. Like what works here in Summit County, I wouldn't tell you would work in Metro Denver, would work in Southern Colorado. What works, what the STAR program does in Denver, I don't know that type of program would be successful here, because we've designed a program along with our community partners that works here in Summit County. It's just, to me, I think the success is designing it with your community and figuring out what your community needs. And if you have your community behind you and they approve of what you do and they're part of what you do and they're at the table, as both the previous presenters said about that, they have community stakeholders come to the table and offer governance and guidance and suggestions. We do the same thing here. And I would tell you that, I duplicated the we've done in the community now in the jail. So I have a dedicated mental health team in the jail that also does medication assisted treatment, that does Narcan, that does medication consistency program, all of these programs that, again, when I was telling you about the crisis in our community, it was a crisis in the jail as well. And I can tell you that it has brought stability. Our community is more stable. The jail is more stable. And that it's been a success for the community. It's not our success. It's not the SMART team's success. It's the community's success. And that's what I think is missing from all this focus on, is it a paramedic and a clinician? Is it a cop and a clinician? Is it, I think we really need to pay attention to what is the best thing for the community, and does the community have a say, and do they have buy-in? I wouldn't do anything without my community partners. I mean, I really, really cherish my community partners.
And I think that's really smart. And I also think it's a great observation that so much of this, whether it be law enforcement or EMS, is fairly regional and needs to be tailored to the particular community. And what's been remarkable, and I appreciate that of all of our panelists, is being able to find ways and find successes for their own community. With that in mind, what advice would you give either to other people in Colorado who are looking to try to duplicate, and again, not duplicate the model, but duplicate the success? And I'm going to ask Justin and James to also weigh in here in just a second about what advice you'd give to other people, but we'll start off with you, Sheriff.
So for me, I would say, instead of building it from the top down, from the law enforcement agency down, build it from the community up. Figure out what the community needs. I would also make this comment, in this world of police reform and co-responder, and what does co-responder look like moving forward? Because there's a bill there in the legislature right now that's being heard. In fact, this coming Tuesday, about co-responder. I would tell you that this is not easy. It's not easy for law enforcement. Speaking for myself, it's not easy to stand up and manage a team like this. My team is co-managed by a lieutenant on the law enforcement side and also a clinical program manager for the clinical side in both teams, both in the community and the jail team. But I would tell you that it's not easy. And so that's why you don't see every law enforcement agency doing it. But I would tell you that what we all have in common, and whether it be the STAR program or a co-responder like my type program, where you see a law enforcement executive getting involved in co-response or a jail-based program, you should probably listen and try to support it, because it's not easy, and it must be someone like myself that is passionate about mental health, that is passionate about making an impact on the community, that is passionate about really saving lives, and trying to take away that interaction between uniformed police and people in crisis. You know, the law enforcement agencies here in Summit County are absolutely not shy about jumping on the radio and asking for a SMART team. You know, I mean, and the SMART team is absolutely not shy about buying a call. And when I say that, people don't know what I mean is hearing a call on the radio and saying, we'll take that call. So, you know, I would tell you again, there's many more agencies that are not getting involved in this. And I would tell you, because it's not easy, and it takes a passionate police executive to get there on the front lines and wave this flag. But that's what my community expects of me.
Yeah, we appreciate your passion. James, when you and I first spoke about this, you told me of a couple tragedies that had happened in your community. Maybe you could tell us a little bit about your community involvement and some of the things that started to drive your program.
Yeah. So, you know, and when you hear this story, if you're involved in first response at all, it's gonna ring true to you. And that is, you have a client, you run on them, and the services aren't there in your community. The partnerships haven't been established, and you see this person heading towards a precipice, and you try and get them the help that they need, and you try and put them in touch with the resources. But the reality is you don't have the knowledge, skills, and abilities to make that happen. And you don't have those partnerships in place to make that happen, to empower that client to get the help that they're reaching out for. So you do what you can do. You take them to the emergency room, and they get cut loose, you know, and then they go back home, and the same behavior pattern occurs again and again until you have a tragic outcome. And we had a couple of cases like that where the resources didn't get to the client, and unfortunately the ending was very tragic and had just incredible wave impact on the community as a whole. We know that for every completed suicide in our community, the immediate downstream costs are about $26,000 in real dollar costs, and the human impact, especially of the loss of a young person, is unmeasurable. And then the impact to the first responders that have been there, that have worked with those clients, it's devastating. So if I was going to give any advice to someone looking to start a program, I think first of all, what Jamie said is spot on. Each community has to develop a program that plays on the strengths and weaknesses of their community. No two programs should look alike, because no two communities look exactly alike. You have to draw on the people that are passionate for providing those services in your community. And you have to work with the partners that you have and that are available to you, the resources that are available to you. So the first thing is, honestly, be the agency that steps up and hosts a meeting. Bring in all the partners, bring in the school districts, bring in your private behavioral health partners, bring in your public behavioral health partners, bring in your law enforcement agencies. Please bring in EMS. You know, we're struggling with this too. Bring in your hospital systems or the closest hospital system. And then work with all of those partners to outline, first of all, what are the problems you're facing? What are your community needs? Conduct a community needs assessment. And then go out and visit other programs. Anybody who's on here today is welcome to come and spend a day with us. Come see our program. Please reach out to Jamie, reach out to Justin, see if you can visit with them and learn from their programs. And I absolutely plug the CRT program in Colorado Springs. What they're doing is absolutely amazing down in that area. And the homeless outreach team with Colorado Springs PD. Reach out to those agencies that are doing innovative programs, and, there is no one size fits all. Look at what they're doing, and then look at the resources that you have in your community and the people that are interested, and put it together. Honestly, for us, I hate the term, but it was low-hanging fruit. The partners that were willing to work with us is who we started out with. And then as we started showing success as a partnership, other folks hopped on board. So start with a meeting, do a community needs assessment, go out and see other systems. That's the best recommendation I could make.
Tom, you're muted.
Yeah, I got that figured out now. I only did it once though. So I would also want to make sure we're inviting people to put questions into the chat. But Justin, do you mind, what advice would you have? And let's see what questions come out of our participants.
You know, I don't have much to add. I think the Sheriff and James really adequately covered exactly what it takes to get this going, other than just having the initiative and you know, starting to make those community connections. And you know, I remember having this conversation about 4 or 5 years ago with some community partners about what a mess it would be to try to tie 911 in the city and county of Denver and the paramedics and the fire department and the police department together to try to get a resource like this together. And really it's about taking those first steps and how important that is. There's a lot of initiative out there. There's a lot of drive for these types of programs. So starting those conversations in your community is step number one.
Tom, you're muted again.
Yeah, I'm going to just keep unmuted. This is a question about funding with these programs. And I know, Chief Harper, you're on a grant, and then both James and Jamie have some tax base. But what is the, how is it that you look to sustain funding, and any advice on doing what can be an unpopular thing, which is raising taxes? Sheriff?
Oh, I'm sorry. You know, we're funded through a grant at Office of Behavioral Health. We're funded through a grant at DOLA, Department of Labor Affairs, Local Affairs, and we're funded through this tax initiative, the Strong Futures Tax Initiative currently. But I would tell you that, you know, part of the frustration, part of the hardship and challenge of running these programs is going with hat in hand looking for money. You know, no one grant funds anything 100%. They're all very particular about what they will and won't fund. You know, I'm very fortunate where I have this ballot initiative that kind of picks up what other grants won't pick up. But I would tell you that it's a struggle. You know, the other struggle is the reporting requirements for these grants. You know, in small rural agencies like here in Summit County, you know, we're all the same people. I don't have a grant person that works for me that seeks these out, that reports on them, that manages them, that, I mean, it's a full-time job in itself. So it's difficult. I'm looking at other funding options here within the community because it's exhausting walking around with hat in hand, asking for money. But, you know, the proven success of the program itself is what now, you know, in the beginning, it was obviously tough the first year, but now we've got a year under our belt and we've got such proven success in the community that I'm anticipating the ask this time around is going to be a lot easier.
Well, it certainly helps when you have successes and you have data, and particularly James is talking about saving money. And so that's critical. There's another question, and I'll direct this to you, Chief Harper. Do you know about other communities in Colorado that have similar programs like the ones we've been talking about this morning? And then, and again, I'm asked, it's a tough question, but the question is about Elijah McClain. And do you envision how that might have played out differently if it had been a STAR unit assigned to that a person waving his arms and acting strangely versus a law enforcement response? Would you mind tackling that, Justin?
Sure, and you know, speaking to the other programs, we've been in contact with a lot of other cities and towns in the state and in the country, particularly Arvada, Aurora, Colorado Springs and other municipalities that have been looking at a similar program to STAR. And I think Aurora is up and running with a pilot that is very similar to the STAR program. They're working with their EMS agencies and the fire department there as well. And, you know, I think from what I've seen in my anecdotal personal experience on that STAR van versus my experience as a paramedic, is that absolutely, I think an encounter with a mental health professional and a healthcare provider that have the angle of how can I help you would be a very different outcome with the Elijah McCain situation. You know, that would be my personal opinion, and I think that's, you know, why we're so invested in trying to not only help our community, but help our police officers and not putting them in situations that they shouldn't necessarily be in. They're not healthcare providers. They're not mental health care providers in the roles that they're in. And it's unrealistic and unfair to put them in those situations. So how do we help them and support them? And that's our goal.
And you and I are really like-minded on this, and we've talked about this before, that I think we have some responsibility to our law enforcement partners to protect them from situations where they're getting, I don't think any of those officers in Aurora woke up that morning and said, today we're going to ruin somebody's life. And that it is just I think we ask a lot of our law enforcement partners, and that perhaps there are these other resources that can intervene with these sorts of cases, which keeps the public safe, but keeps the people in the community safe, and keeping our law enforcement partners safe. What's been remarkable to me, and at least in my 30 years in EMS, it's always been, if somebody's behaving badly, send the police, because we're going to injure EMS providers and they're just not trained for it. And so it's remarkable to me. Justin, you talked about STAR unit has not had to ask for police cover. The sheriff was talking about how his unit has not had to affect arrests or mental health holds and so on. And so, James, do you mind weighing in? Your program's been around the longest. How have you dealt with this idea that somehow we're going to injure healthcare providers in these interactions? And have you had incidents where someone said, with 2020 hindsight, there should have been a police call?
No. So with our program, if it sounds like it's a dangerous situation, obviously we're going to bring law enforcement in early with us as part of the team. So they come in with us, we come in together, and we come in from the approach that the client is going to set the tone. The client's going to set, you know, if they need to rage, we'll give them space to rage. As long as they're doing it in a way that doesn't impact, you know, doesn't endanger themselves or anyone else immediately, it's okay to scream and yell and let out that frustration and that anger. And, you know, even if you want to break things, you know, really, we'll give you the space to do what you need to do. And then we'll meet you where you're at. We'll come alongside you and we'll actively listen. And as soon as that provider feels safe, we'll cut that law enforcement officer free to go and do what they do. We haven't had any issues with this at all. The only struggle that we've had through the history of the program is with the changes in law in Colorado. There's a lot of times when law enforcement have to back out of the scene now when there's a weapon involved and there's no one at risk. And so historically they would have gone in, secured that scene for us, and we'd go in and meet the client there. Now what we do is we take what's called an indirect map approach, where we actually reach out to that person through other means of communication. So either telephone, text message, email, and we're communicating with them that way. And what's amazing is a significant number of these clients do engage with us indirectly, especially through text message. And we can keep them engaged sometimes for hours via text message. And we've been able to, in a lot of cases, more than 50% of the cases, we've been able to get those clients to agree to meet up with us somewhere else where it's safe for them and safe for us on some neutral grounds. And so that's been a tool that's been fantastic for us. We're actually putting our providers through the FBI crisis intervention 1, 2, and 3, so that they garner greater skills in working with clients in behavioral crisis over the phone. And so I think we'll yield even greater results over the long run with that. And then speaking to the medication piece, for us, what we've done is from early on, we've tracked any behavioral medication that we've given, the time it was given, and about 26 criteria around that medication's use, so that we can better understand and tell a better story from the broader perspective about when we're using medications, how we're using medications, and if we're, to make sure that we're being an advocate for the client when that becomes a necessary solution. Most of those clients are the ones that end up going to the emergency room, but we do use Zyprexa and Geodone for patients who are agitated, who want help, who want to decrease that agitation level so that they can engage better and become more empowered to manage their illness.
And that is the by mouth preparation. It is not
correct.
It is not the shot.
Nope. They have to voluntarily be willing to take those medications. And then again, we make space and create time to allow those medications to start working so that the client can regain control. But it has to be something they want to do voluntarily. And so that's where that motivational interviewing piece comes in. We want to identify what drives them to want to change the situation that they're in that moment. So I hope that answers the question.
Yeah, it does. Thank you. And also another question for you. What's sort of the best way to distribute information on help numbers to rural and farming communities? And we can expand that to ranching communities, I think. And so I think the question is along the lines of, how is it that you, if you will, advertise your services? And how is it that we make people, even in rural areas, that may not realize that there are these kinds of teams, and that that there is money available, or that there is funding to get somebody evaluated at the 2 hours at the maximum anywhere in the state if they are experiencing a mental health crisis?
A great question, right? In the rural environment especially, it's really hard to find those opportunities. And I'll tell you, it's a 2 birds with 1 stone kind of thing. The other question was the tax piece. So when we passed our tax initiative, we went to every farmer's market, every public event, everything we possibly could to share with our community this program and the importance of sustaining it with the 1/2-cent sales tax. And that's the same way we continue to share word about the program in general. We go to the farmers markets, we go to the community events, we go to all of those functions, and we have literature. We let folks know about not only our MAP program, but we also let them know about our telehealth services that are available. We let them know about resources that are available in their community, CPR classes that we have. And we literally spend our entire time during the summer, especially, reaching out, and then we speak to any community partner that's willing to open their door and let us in. So senior coalitions, homeowners associations. We look at it as we are constantly campaigning to show our community that we are the value option in our community, that there is absolutely value to them to sustain the programs that we do. Tom, I'm so sorry, brother. I can't hear you.
I just have to leave myself off of mute is what I have to do. I really appreciate that. It's really smart what you guys do. And another question that's come up for the sheriff. You had previously mentioned interactions with individuals who may have intellectual disability or learning disabilities who are experiencing crisis. And how is it that your team may change their approach, or how is it that they may handle that differently?
Obviously they're trying to recognize the difference between a mental health crisis and some of these other disabilities. And they, it's such a large question, right? There's so many variables in that response, but they're trained to handle the response appropriately. But, it brought me up, it brought me to the SMART team had a client that had an explosive disorder. It was a young person, a juvenile. And, every time they had an aversion to people in uniform, to fire and law in uniform. And, once the team started working with this kid, and I mean a kid and his family, and mentoring this kid, they were able to teach this client how to act when they see a uniform. So that the child wouldn't get hurt, wouldn't turn into a use of force situation, because literally, a really violent, explosive disorder reaction to uniforms. And so they worked with this child, they worked with the family. This child was down in Denver at a dentist appointment. And this is after, working with this family for a while, and had one of these reactions to the dentist all of a sudden in the way they were dressed. Of course, the dentist calls law enforcement. Law enforcement responds, and it was pretty incredible because of the way the kid remembered to interact with law enforcement, to calm himself down, some breathing techniques, how to show that he wasn't a threat to law enforcement, to the point that when law enforcement came and they finally were able to resolve the incident, that the law enforcement officer called our SMART team, because the kid told them about the SMART team, and told them about this incident, and that their training paid off, that there was no violent interaction with this kid, that he immediately did what he was trained to do through the SMART team. And you want to talk about an unbelievable outcome, and also from the parents that witnessed this whole thing, both in the dentist chair all the way out to outside to where law enforcement had the interaction with the kid. So, just that's what reminded me of asking that question, reminded me of, here's someone with not only mental health issues, but some other critical issues.
And probably have been traumatized in his past, no doubt.
Oh, yeah.
And so what a great story to go out on. And I just want to be aware of our time. I want to thank our panelists very, very much for your insights and for your thoughts and for your programs. It is really remarkable. And I think this is the future is looking to be able to address inequities with populations that often or don't have access to certain treatments by implementing field providers, and also being able to save their communities time and money and bad outcomes by keeping them away from jails and keeping them away from hospitals. And so I'm going to end my time and just throw it back to Don if you have any closing thoughts. But again, thank you to our panelists, and thank you for everybody who's joined us today.
Well, thanks, Tom. I just want to speak on behalf again of Colorado Healthcare Ethics Forum that this has been an amazing presentation, and all three of you evince the characteristics that Jamie described of passion and commitment and leadership, and that's really what it takes. I hope that these programs can promulgate throughout. I know that our state legislature also should have a stake in this matter, and I hope that they will find some way to relieve some of the funding issues that you have described. So we're out of time, but I think it's Constance also has entered a chat comment. Thanks for your presentation. Excellent work. Tom, your moderation has been amazing. Truly awesome. Thank you so much.
Thanks.
So
This
that,
time I'm going to make sure I'm unmuted.
We'll end the program. Thank you.
Thank you. Be safe, everybody.
Thank you, everyone. Thanks, Tom. Thanks, Don.